but it doesn't work up front. And so this is the rough period when you need to be at the patient's bedside every second and translates into the mortality risk. Our solution showed excellent immediate function and later function. So we developed a technique where we could store a lung for 12 hours and have it work more reliably right after we transplanted. And this really transformed lung transplantation worldwide. This is what human lungs look like when you preserve them. So we keep them inflated with air so the lungs actually have oxygen while they're outside the body, and the cells are able to access the oxygen. And they're flushed with the low potassium dextran solution. And we showed that this improved the outcome and the immediate function of lungs in a clinical trial after that in our lung transplant program. And our problem, as you can see here, this is the number of donors in our region in Ontario. And you can see that from 1991 to 2009, you still have a significant problem. That these are the number of donors in our region. We are getting slightly better over the last 4 years, but we have a lot of work to do to educate people about the benefits of transplantation and how you can save lives by being an organ donor. Nevertheless, this graph shows the number of transplants of all organs performed from those multi-organ donors, but the number of people waiting for a transplant far exceeds the number of lungs and other organs that we have. So in spite of this, over that same time period, we have doubled, tripled, quadrupled the number of lung transplants performed in our program. And in fact, this year we just passed a major landmark of having performed our 1,000th lung transplant in this program. And when you look at the transplants we perform, in blue are the double lung transplants in patients that require both lungs transplanted. In green are the single lungs. There are many diseases where you can treat a patient by just providing one lung, and then there are some patients who have heart disease and lung disease and need replacement of both organs. And when you look at the results, in spite of being able to use more lungs, repair lungs, learn to treat them, and so on, and really push the boundaries in doing higher risk patients, older patients, patients with other diseases, we have really kept the operative mortality or the risk of this operation in a very low range, which is actually the leading in the world. And I showed you the start of that mortality curve, and we have continued to drop the operative mortality while we continue to increase the number of patients that we apply lung transplantation and extend the boundaries of what we can do. So who do we treat with lung transplantation these days? There's cystic fibrosis, about a quarter of the patients. Idiopathic pulmonary fibrosis, a scarring condition that we don't know what causes it, in about a third. Emphysema or COPD in a third. And then a variety of other conditions. Bronchoalveolar carcinoma is one kind of lung cancer that we're starting to treat, pulmonary arterial hypertension, and some patients need a retransplant as well. In children, which is part of our program as well for lung transplantation, the majority of them need a transplant for cystic fibrosis. There's some of the pulmonary arterial hypertension diseases as well in children. And just to show the difference in activity, we do about 20 adults for every one child that needs a lung transplant here in Toronto. We've continued to push the boundaries in where we can apply lung transplantation and in unique applications. This is a lady that had a tumor of her uterus and had a hysterectomy 20 years before, and she developed metastases or spread of the tumor to the lung. All of these white dots are tumors in the lung, and basically she developed lung failure because of the amount of tumor in her lung. Black is air, white circles are tumor there. And we performed the first transplant for that condition, where now you can see her new lungs, and she's doing well, having had a lung transplant to replace lungs that had been filled with this unique tumor that spread only to the lungs and nowhere else, where we could do the ultimate tumor operation and remove both lungs and give the patient 2 new lungs. This is a patient who got bronchoalveolar lung cancer. This is a lung cancer which is the most common lung cancer in non-smokers, and it tends to be bilateral, come in both lungs as you see there. And you can see that there's cancer in that lung, there, and this is not operable because you can't usually take all of the lung out. But for these few patients, we've been able to give them new lungs and improved survival over time. And we continue to look and see how we can apply lung transplantation to improve both the quality and the quantity of life for patients with various diseases. So what can you expect from lung transplantation? The 5-year survival is about 60%, and the 10-year survival is about 40%. In fact, we have several patients now around that are out over 20 years from a lung transplant. And these are patients who 20 years ago had 6 months to live. So not everybody makes it. We have problems with chronic rejection. Your body continues to try and fight that foreign object or organ. And you have to, a big part of our research is to make the body tolerant to the organs. So can you make them accept the organs? And the other complication is infections related to the fact that you suppress the immune system so you don't fight the new organ, but then you're more vulnerable to infection. So we have to walk that tight line, and this is where the gains will need to be made in the future of transplantation. But comparing our results, despite being an aggressive program and an innovative program out leading, our results are superior to the International Society of Heart and Lung Transplant Registry, where all the programs in the world submit your data, and then you can compare yourself to other programs and benchmark where you sit in the world. And more importantly, in children, we've been able to show that our outcomes are actually far superior to the International Society of Heart and Lung Transplantation data that's been published. So we can't achieve this without a very big team, and many of you have experienced this, know that it is a fantastic team of committed individuals. Every one of them, whether it's nurses, physiotherapists, surgeons, respirologists, psychiatrists, coordinators, infectious disease specialists, they all commit and are excited about being part of a leading program where we can improve the survival of patients with lung disease. Now, we still have a problem, though. As I showed you, the number of donors available is far less than what we need to treat patients with end-stage lung disease. So in this slide, in green are the number of patients that are listed every year, in blue are the number of patients we transplant, and in red are the patients that die on the waiting list. So despite being a good candidate that could get a lung transplant, 15 to 20% of our patients will die before they get a chance to get a transplant. So what can we do to solve this problem? The first thing is we can put patients on a mechanical ventilator, the standard ventilator in the intensive care unit. And while that used to be a very high-risk endeavor and still is, we're doing it more and more in selected cases where we can just carry a patient long enough to get a donor organ. We've also gone to using extracorporeal life support, or ECMO it's called, extracorporeal membrane oxygenator, or the Novolung, which is an artificial lung that really isn't the ultimate perfect artificial lung yet, but now can support someone for a month or a month and a half before they get a donor lung. And so that has been one other option, and I'll talk a little bit more about it. But clearly, we need to improve the availability of the donor organs, and I'm going to show you ways of how we've worked to improve the availability and quality of the organs that we currently have in the donors. So can we bridge patients who are very sick to lung transplantation with an artificial lung? The conventional extracorporeal, so that's outside the body, membrane oxygenator, is really, this is the membrane and this is a pump. So it's basically a heart-lung machine that replaces the function of the heart and the lung. And that's sort of technology that's, slightly improved a little bit here and there over the years, but has problems with its complications and challenges. A few years ago, a company in Germany, Novolung, developed this device, the Novolung, and you can see it's quite small. It's the size of a CD cassette, and it has two cannulas, one on each side. One you put into the artery in your leg and the other one into the vein in your leg.